আসসালামু আলাইকুম। আমন্ত্রণ জানাই এসিপি বাংলাদেশ এবং বাংলাদেশ সোসাইটি অফ মেডিসিন কর্তৃক আয়োজিত সাপ্তাহিক স্বাস্থ্য ও শিক্ষামূলক অনুষ্ঠান হেলথ টকের দ্বিতীয় পর্বে। আপনারা অবগত আছেন যে হেলথ টক নামক এই প্রোগ্রামে আমরা প্রতি সপ্তাহে আমাদের দেশের স্বনামধন্য প্রফেসর স্যারদের মধ্য থেকে একজনকে আপনাদের সামনে উপস্থিত করার চেষ্টা করি এবং তাদের অসীম জ্ঞানের ভান্ডার থেকে কিছু জ্ঞান আহরণেরও চেষ্টা করি। আজকে আমাদের সাথে বক্তা হিসেবে উপস্থিত আছেন আমাদের সকলের প্রিয় প্রফেসর ফিরোজ আহমেদ কুরেশি স্যার। স্যার বর্তমানে প্রফেসর অ্যান্ড হেড অব দ্য ডিপার্টমেন্ট হিসেবে দায়িত্ব পালন করছেন আনোয়ার খান মডার্ন মেডিকেল কলেজ অ্যান্ড হসপিটালে। আজকে আমাদের প্রোগ্রামের চেয়ারপারসন হিসেবে আছেন আমাদের সকলের শ্রদ্ধেয় মোহাম্মদ আব্দুল জলিল চৌধুরী স্যার, ফর্মার প্রেসিডেন্ট অফ বাংলাদেশ সোসাইটি অফ মেডিসিন অ্যান্ড ফর্মার চেয়ারম্যান অফ ফ্যাকাল্টি অফ মেডিসিন বিএসএসএমইউ। আজকে আমাদের সাথে স্পেশাল গেস্ট হিসেবে আছেন আমাদের সকলের পরিচিত প্রফেসর কাজী দীন মোহাম্মদ স্যার, প্রফেসর অফ নিউরোলজি এবং ডাইরেক্টর অফ নিমস। এছাড়াও আমাদের সাথে আছেন আমাদের সকলের প্রিয় এইচএম নাজমুল হাসান স্যার, গভর্নর এসিপি বাংলাদেশ চ্যাপ্টার অ্যান্ড ফর্মার প্রেসিডেন্ট অফ বাংলাদেশ সোসাইটি অফ মেডিসিন। আজকের প্রোগ্রামের মডারেটরের দায়িত্ব পালন করবেন ডক্টর শর্মিষ্ঠা বিশ্বাস ম্যাডাম, সেক্রেটারি টু দ্য গভর্নর এসিপি বাংলাদেশ চ্যাপ্টার অ্যান্ড অ্যাসোসিয়েট প্রফেসর অফ মেডিসিন ঢাকা মেডিকেল কলেজ। আমি ডক্টর প্রিন্স কাউসার সঞ্চালক হিসেবে রয়েছি। আপনার প্রোগ্রাম চলাকালীন সময়ে আমাদের ফেসবুক লাইভ অথবা ইউটিউব লাইভে কমেন্ট সেকশনে আমাদের প্রশ্ন করতে পারেন। আমরা চেষ্টা করব লাইভেই প্রশ্নের উত্তর দেওয়ার জন্য। এই পর্যায়ে আমি শর্মিষ্ঠা ম্যাডামকে অনুরোধ করব প্রোগ্রামকে মডারেট করার জন্য। ডক্টর শর্মিষ্ঠা ম্যাম।
Thanks, Dr. Prince. Learned viewers, good evening. As you have heard, ACP Bangladesh chapter has taken the initiative to conduct some educational program on a weekly basis. This program is supported by Bangladesh Society of Medicine. Thanks to BSM for their generous support and cooperation. So let us start the session. May I request Professor Firoz Ahmed Qureshi, Professor and Head, Department of Neurology, Anwar Khan Modern Medical College, and the President, Bangladesh Society of Neurology, to talk on
full screen. Slideshow. Thank you. Am I audible?
Yes.
Yes. The chairperson of today's session, Tajidin Muhammad, my favorite teacher.
Slide.
And my mentor.
Chairperson Jalil Chaudhary.
And chairperson, Professor M.A. Jalil Chaudhary, Professor of Medicine, who is a very good elder brother of mine, and the Governor of ACP chapter, Professor Nazmul Hasan. He is also a very good friend of mine from since more than 25 years. So I oblige both three of them. And I am greatly thankful to Professor Shormista, who is very close associate to me. Thank you all, and also welcome the participant and start the brain images of the city or CT scan of the brain. You see, from since the Second World War, after the invention of the X-rays, there is tremendous increase in the diagnostic and pathological findings of the whole of the organ of the human being. One of the spectacular advantage of scanning of the whole of the human body is CT scan and that of the MRI. This has ultimately changed and revolutionized the diagnostic and pathological aspects of the human disease and human body. So knowing the CT scan and the MRI has become a very foremost duty for the clinicians, especially the radiologist together with the clinician. A clinician has to diagnose the case with the signs, symptoms, with the help of the various diagnostic modalities together with that of which the diagnostic modalities CT scan and MRI plays a very vital role. So this chapter is intended to give a overview of the CT scan of the brain. As a neurologist, this is I just
Slide 2.
When you go for reading the CT scan, you must have the anatomy. Brain is a very complex, so anatomy is a complex one, but we don't want to go into the complexity. The thing is that when reading the CT scan, you read with the three planes. It is an axial plane, that is this plane is the axial plane. and there is a coronal plane that is going through the coronal sulcus, and this is the sagittal plane going through the sagittal sections. So these three are the main sections in the imaging of the CT scan. You can see there are various anatomical location, and the sections will depend upon the anatomical locations will depend upon the sections. I don't want to go into the detail. Everyone has an idea of the CT scan. You see, this is a calvarium or bone. This is the cerebellum. This is the cerebellum. This is the optic. This is the eyeball. This is the paranasal sinuses. And you can see the various structures have a definite look, like that of the human beings. No human beings is similar to our except twins. So this is a different look, and you must identify the look. You can identify a person by looking repeatedly with it. So the main stem of looking into a picture or reading a scan or X-ray is that you go and practicing it. This is a coronal section. You can see this is the ventricle. These are the ventricles. This is the brain stem portion, and in the sagittal section, this is the ventricle, and above it there is a corpus callosum. This is the corpus callosum. This is the fourth ventricle. It lies in front of the cerebellum, and this is the cisternus, and this is the cisternus, and this is the bone, and this is the ear in the sinuses. So you can see the ear has a peculiar character. This is the ventricle, that is the water, has a definite character, and this is the brain parenchyma. This is have a different character, and this is the calvarium or skull, which has got other different characters. So we must identify by seeing the characters.
Slide 3. Slide.
Now, reading the anatomy is very important. I don't want to go into the details, just a very popular section of the brain. This is the section through the internal capsule. Now, I just go for a identification of the important organ here. This is on the middle. You can see just a sickle cell shaped blackish. This is water in the ventricles, and this is the lateral ventricle. This is the frontal horn. This is the frontal horn of the lateral ventricles. This comes here to the slit, like this is the third ventricle. And on the lap of the ventricle, you can see just a bit hyperdense area, which is the head of the caudate nucleus. You go beyond, there is a lens-like structure. This is the globus pallidus, and this is the putamen. And between this caudate nucleus head and the putamen, there is an hypodense area going through. This is the anterior limb of the internal capsule. This is the genu of the internal capsule going back to that of the posterior limb of the internal capsule. Just lateral to this is the third ventricle. This too is very important structure in medicine. This too is the thalamus. This is a very important thing. Go posteriorly, there is an hyperdense area. This is an pineal gland calcification. And goes to this is the lateral ventricles, and these are the calcification of the posterior horn of the or occipital horns of the lateral ventricle. And this is the main sulcus, that is the longitudinal sulcus going in between. And this is a frontal lobe, this is a parietal lobe, and this is an occipital lobe. So this is an anatomy. I don't want to go into the detail. What is all of you know it.
Slide 4.
Now,
Slide.
when you go for expressing the pathology of a CT scan, we have three things. Number one is some of the things are hypodense, some of the things are hyperdense, some of the things are isodense. So there are three types of the density we can identify in CT scan. When you go, the water has a density 1 or 0, and when you go to the hyperdense, the bone has the highest density, and when you go beyond it, air has the lowest density. So we compare the density to that of the water, to that of the air, and to that of the bone. Now see, this is the air in the sinus. So this is the air in the sinus, and you see this has got a very difficult, very different entity to that of the water in the ventricles or CSF. So bone is hyperdense, blood is hyperdense. It may be hypodense also, it may be isodense also, depending upon the time on which it is acute, subacute, or chronic. So the main thing before reading a CT scan, you must remember blood can be very bad. this thing. Blood means B, C means cisterna, B means brain, V means ventricle, and B is below and above the bone. So always search for the blood that is hyperdense or isodense in the cisternas, in the brain, in the ventricles, and below above the calvarium or bone. Stroke, which may be ischemic, it causes hypodense to that of the isodense depending upon this, and hyperdense in that of the time, that is the hemorrhagic stroke, it causes hyperdense shadow and it becomes hypodense with that of the time. Mass effect is very important to identify in CT scan. This is very important. You can identify the mass effect by edema, the shifting and compression of the ventricles, midline shift, and herniation syndrome. You must identify these four: edema, shifting, compression of the ventricle, midline shift, and herniation syndrome. These four is very important. So from this slide, I will identify that when the density is like that of the water or to that of the CSF, it is hypodense. To that of the air, it is more hypodense, and to that of the bone, it is more hyperdense. You see, the more hyperdense from brain, white and gray matter, then blood, then calcification, then that of the bone. This is the primary thing you must identify and you must remember. Next.
Slide 5. Slide.
We are the physician. We are to not only like that of the radiologist, we don't report it. You are on the bedside. This is very important. And you are the sole responsible of the patient you are taking care of by diagnosing. Number 2, by treatment, and also the fate of the patients. So you must know the etiology. Brain is an organ that has got the various etiologies inflict that of the cause of the diseases. So we can go through it, all of the diseases. But remember, vitamin D3. V means vascular, that is ischemic or hemorrhage or subarachnoid hemorrhage, AVM. These four as the main, you can see this is the main cause of the CT scan, doing CT scan of the patients, more or less 70 to 80% of the cases, because stroke is the second most commonest cause of the death and disabilities. Number VI, it is infection, it may be viral, bacterial, protozoal, fungal, you will identify in the CT scan. Traumatic, this is one of the important. So 1, 2, 3 are the major cause of the CT scan presentations or presenting with the CT scan. So don't forget, is common things presents commonly, and common things sometimes presents a very unusual feature. So you must search these 3 VIT. A is the autoimmune. This is the vasculitis or sarcoid. You must you sometimes encounter it. Metabolic, especially the chronic liver disease. Patient presented with a confusional state, you can detect the metabolic in chronic liver disease, especially in MRI. Iatrogenic alcohol and the drugs is very important. Alcohol, sometimes methanol poisoning can have an effect on the basal ganglia and surrounding area. Neoplastic lesion is one of the commonest presentation, and it may be primary, secondary, or degenerative disease of the brain, motor neuron, and Parkinson, very rarely given in the examination purpose. Demyelinating disease, sometimes it comes into the examination. Multiple sclerosis, NMO, and MOG antibody disease are very important. Developmental disease, syringomyelia, sometimes comes into the examination. For examination and common purposes, you must have the vascular, infection, traumatic, and also neoplastic diseases and demyelinating and developmental diseases. So we can identify the etiology of the CNS diseases.
Slide
Next.
6. Slide.
What is the pathology? You go on the pathology. So this is the fundamental slides. You must have to identify the pathology. Very important, and then go to the etiology. So I have covered the etiology, and this is the pathology, because etiology is, you are more familiar to that of the etiology than that of the pathology. So when you go read the CT scan from above downwards and below upwards, you go screen up and down, and you see whether there is hyperdense or hypodense or isodense lesion. So these 3 is very important. When you go for an hyperdense lesion, you go from to the paracalvarial area, that is below the bone. Is there anything below the bone? What are the commonest below the bone? They are, 1 is the epidural hematoma, number 2 is the subdural hematoma, number 3 is subarachnoid hemorrhage. Just remember these 3: epidural, subdural, and subarachnoid hemorrhage. These 3 are the major causes of the paracalvarial hyperdensity. How do they look like? The epidural hematoma, just remember one lemon. This is like lemon. You see a convex, this is like lemon, And subdural, just imagine a banana. This is the banana, this is the subdural. You see, this like the banana. So lemon and banana, that is epidural and subdural. Subarachnoid will come into the later on with that of the density like that of the blood or hyperdense area. Sometimes the paracortical ICH, there may be paracortical ICH, we will have the slides there. Paracortical tumor, the meningioma sometimes have and confusion. So, but we can have differentiation with it. And cortical calcification is very important. We can have the calcification in Sturge-Weber disease and also sometime in tuberous sclerosis. But they are not common, but sometimes given in the examination both here and abroad. So you must have the cortical calcification. So you remember 4 things: hematoma epidural, chronic and acute, chronic and subdural hematoma, subarachnoids, and also the calcification and paracortical tumors. Next.
Slide 7. Slide.
Now, if there is a hypodense, so there hypodense usually I have shown that the hematoma is hyperdense. First, with the time it goes on to the hypodense areas. So there may be epidural convex. It is a chronic epidural hematoma. Sometimes it is sickle shaped or banana shaped, which is called subdural hematoma, and subdural also there may be subdural empyema. Cortical atrophy. When there is cortical atrophy, there will be sulcus and gyrasis will be prominent, and with that of the CSF like fluid filling. So this is a very important one. Arachnoid cyst is one of the another thing that you can encounter in the paracalvia or the beside the bone. It is the CSF field, so it is the inside is like that of the CSF. Pneumatocyl you can have especially in the post-traumatic or post-operative state, and the appearance is like that of the ear in the sinuses. So don't forget, it is not like this, but it is more hypo than that of the ear. So ear like I have shown you in the parasagittal sinuses.
Slide 8.
Now, now we just move downward from the calvarium, that is from the bone, to that of the intracerebral stage. You know the brain has got 2 parts. Number 1 is a supratentorial part. Number two is the infratentorial part. So supratentorial and infratentorial. So when you go into the supratentorial parts, we have done hemorrhage. That is a hypertensive hemorrhage, which is a very common entity in our clinical practice. So this is a hyperdense area that can give rise to hypertension. Remember, hypertensive hemorrhages have 4 predilection in the 4 sites. Number 1 is the basal ganglia, number 2 is the thus, number 3 is the cerebellum, number 4 is the pons, and lastly cortical. When you see any cortical, you must have to be alert in your mind. These 4 are hypertensive, common hypertensive intracerebral hemorrhage. So everyone has a predilection. So you must identify the predilection. They are homogeneous, and also you see there is this is hyperdense, and it is surrounded by the hypodense areas. You see, sometimes it is like a finger-like projection. You must identify this one. So this is like that of the water, like nearly to that of the water. So this is a perilesional edema, and you will see this has compressed the ventricle. This ventricle has a slit-like. This is a normal. You see, and this has pushed. This is the midline, and the midline has also been shifted. And you see, there is no sulcus and gyrus are very faint. So they are obliterated. So these are there are many. You don't forget to catch the smaller things, because in examination it points. When you only determine that this is a hyperdense area, you get 0.5. When you get hyperdense area with that of the perilesional edema or hypodense, you get 1. When you see the compression of the ventricle, you get more 1. When you see shifting of the midline, you get 1. When you see there is an obliteration of the sulcus and gyruses, you get another 1. So this is a very important. You must not miss any single abnormality, or you must be above the average. So second one is AVM hemorrhage, tumor hemorrhage. When there will be tumor hemorrhage, you can have some slides there. There is calcification. That it may be physiological calcification, that is in the fox cerebri. There may be calcification in the fox cerebri. There may be calcification in the basal ganglia, in the basal ganglion region, and there may be some focal calcification, especially in the vascular areas that will follow the vascular territory. Don't forget, brain has a specific vascular territory, and you have to identify it. Sometimes there may be symmetrical calcification of the basal ganglia.
Slide 9. Slide.
When there is hypodense area in the intracerebral region, in fact comes in a special differential A. It has got a very important thing is that it must follow a vascular territory. Either brain has a two system. Number one is anterior circulation. Number two is a posterior circulation. Anterior circulation constitute of the anterior cerebral artery and middle cerebral artery. Posterior circulation is vertebro-basilar. That is vertebral artery, basilar system, and posterior cerebral artery. So these are the two systems, and everyone has its own dignity and own area of supply. So the vascular area, in fact, always processes in a vascular territory, and it is usually wedge shaped. You see, the base is longer. This is just like a wedge shaped. So this is a wedge shaped. There may be perifocal edema there. There may be tumors also present with some of the hypodense areas. Cerebral abscess sometimes present, especially in early stages, present with that of the hypodense area. Proencephalic cyst, that is cyst oval, sharply demarcated, and also CSF-like density can present with an hypodense area.
Slide 10.
Now, you can have a contrast CT. The contrast CT is the contrast is given in the CT scan. Contrast CT, sometimes a ring enhanced contrast enhanced. This is the you see pre-contrast or before contrast. There is an hypodense area you can see here. When there is contrast, there is an enhancement like ring light. So this can occur in tuberculoma, cystosarcosis, toxoplasmosis, and sarcoidosis. Of them, tuberculosis and cystosarcosis are very important in our country. Metastatic, both solid or from the hematological malignancy, can give rise to the. When there is metastasis, you must assume that the metastatic disease of the brain is from common from the lung, from the thyroid, from the breast, from the kidneys, from the ovaries, and so you must identify these things because you are to give the investigation to the patient where you will search for the secondary primary focus. So you must identify first for lung or thyroid. So these are the very important one. Abscess will have a mass effect and the perifocal edema. When there is homogeneous contrast enhancement, giant aneurysm may come into the differential diagnosis. Note, the giant aneurysms occur either in the ACA territory or in the middle cerebral artery territory or in the internal carotid artery or circle of Willis or in the posterior cerebral. So they have a specific vascular anatomy. This is very important. Tumor or meningioma can give rise to the hypertension. Now, after this, you go into the just go below and see the ventricles. The ventricles is very important. In case of the cerebral atrophy, you see the ventricles will be dilated here, and also there will be dilated of the sulcus and the gyrus. But when you see this CT scan, you see there is a huge enlargement of the ventricle, but you can see that the gyrus and sulci are not visible. This is a very important thing that you must not forget it. In case of the cerebral atrophy, you will have the enlarged ventricle with that of the dilated CSF spaces in the sulcus and gyrus. But in case of any obstruction below any obstruction, you will see the sulcus and gyrus has become obliterated. In the ventricle, you must search for the ventricular hemorrhage if there is anything. Just look below, the hemorrhage will drop below. So these also you must look for the ER. There may be ER, it will be ups and down. So pneumocephalus and ventricular hemorrhage is one of the important characteristics.
Slide 12.
Now, when I go to the brain, brain has a three anterior cranial fossa, middle cranial fossa, and posterior cranial fossa. When you go in the anterior cranial fossa, it is the most common is the infarct of the anterior cerebral artery. This is a very important one. Infarct of the anterior cerebral artery. It is an para. You can see that is para. It is an infarct in the hypotenuse. Among this is a paramedian area. Hemorrhage will also be there, especially in the frontal lobe. There is an hemorrhage due to head trauma. When you find any hemorrhage, you just indicate two things. Number one, whether there is head trauma, whether there is rupture of the ACA aneurysm. And when there is an hemorrhage, there will be midline fissure. There will be blood in the midline fissure. So you search for the blood in the midline fissure. Aneurysm of the ACA territory will be small, and there will be contrast enhances in the intrahemispheric fissure because it lies in the interhemispheric fissures. Sometimes frontal lobe will have an abscess from the and you must then check the paranasal sinuses if there is any abnormality there. tumors in the olfactory group meningioma is one of the important cause of the hyper lesion in the frontal lobe.
Slide 13.
Now you go a little below. You below para and supracellular lesion. These are the very important, and sometimes it's very difficult to diagnose because you can identify this is supracellular. Cellular area is the sphenoid bone, sella turcica. Sphenoid bone just lies in front of the brain, midbrain. This is the brain stem, midbrain, and the pons. It lies in front. So in front of it, the sella turcica, and in the paracellular area or the cellular area, pituitary adenoma is one of the important things that should be identified by a medicine specialist. It is an isodens to that of the hyperdense, extending about the, sometimes you must see the extension to the sella and also invading to the lateral structure. All of you know there is an beside this sella turcica, that is a sella, there is an cavernous sinus, and the cavernous sinus contains very important structure. Number 1 is internal carotid artery, number 2 is sixth nerve, number 3 is third, fourth, and fifth nerve, 2 divisions of the fifth nerve, and also the carotid artery. So this is very important. You can get these abnormalities when you get a paracellular or supracellular or cellular lesion. So they can invade in the cavernous sinus. Meningioma, hypertension around, you can have here. Empty cellular syndrome, sometimes this is a very, patients come with this with the empty cellular syndrome, but this is intracellular receptor density you can have. Aneurysm you can have. I have already told that the paracelsal internal carotid artery, there is marked enhancement with that of the calcification with the rim, and it follows a definite anatomical territory. Sometimes there may be pituitary hemorrhage, especially postpartum in the Sheehan syndrome.
Slide 14.
Now go for the infratentorial lesion, just below the tentorium cerebelli. We have 3 important organs, or 2 you can say. Number 1 is cerebellum, and number 3 is the, you can have the brainstem. It comprises, the brainstem comprises of the midbrain, pons, and the medulla. So these 3 and together with that of the cerebellum. So this is the cerebellum, this is the cerebellum, this is the brainstem above the midbrain, pons, and the medulla here, and also this is the fourth ventricle. You see the tent-like structure, fourth ventricle. This is the aqueduct of the Sylvius. This is the corpus callosum. You see, this is the corpus callosum. This is the genu of the corpus callosum. This is the splenium of the corpus callosum. And this is the whole of the cerebral hemisphere. This is the sagittal section. This is an MRI section. So I have seen that this is, you can see here there is hypointense area here. You can see it's a large area, and this is like that of the CSF. So this is the large arachnoid cyst. This is for your example only. So this is the infratentorial lesion. We can look in the cerebellum or in the brainstem.
Slide 15.
Now we go. Now I will go into the practical areas. I had an intention to go a little with that of the showing first the CT scans, then go for the scenario the CT scan, then for the, but with the strength of the time I have just compressed it. Let us see. First case, a 65-year-old man presented in the emergency with confusional state. He studied the displayed non-contrast CT scan of the head and answered the following question. This is a very simplified question you have been given, 65 years. Now you go to the CT scan. You go from the below upward. You see, this is normal, this is normal going on. This is normal, this is normal, this is normal. But you see, when you go, you compare this first and second, third. But here you can see there is temporal horn is a bit enlarged. Now you strike your head. This is an abnormal temporal lobe. There is temporal lobe has become enlarged. This is enlarged. When you go here, you see there is an paracalviar area. There is adjacent to the bone. There is an hypodense followed by the hyperdense area. Now you go below. This is more evident. This is a hypodense. This is followed by the hyperdense area, and also there is obliterated. No sulcus and gyrus is here. This ventricle has become pushed to that of the opposite side. This has pushed or to that of the opposite side. There's midline shifting. So overall picture, now it is clear to you. That is the mention the abnormalities. I have put the dot because there may be various abnormalities in various pictures. So I have not given it. The abnormalities in the CT scan. There is hypodense. It may be hyperdense. It may be isodense. So this is an hypodense and hyperdense. So you can adjacent to the calvarium or bone. on the left or right side or anything, it may be left or right side of the brain. The convexity inward, this is a very important one because I have told the convexity is very important or sickle cell like. There is midline shift, I have already told. There is ventricular effacement, we told it, and to the opposite side there is, and you must look for the fracture. When you see this you must look for the fracture. So this is very important, you must miss it. So this is a very important one. So this is an acute and chronic subdural hematoma. As a physician, now the next question is that enumerate such point in the history to evaluate the possible cause of the above CT scan. So what has caused this CT scan? So you must ask in the history of the trauma. Number 2 is the antiplatelet drug is very important. Anticoagulant is very important. Bleeding or low platelet count or thrombocytopenia is one of the important cause, and coagulation disorders are the important cause in the history. You must ask the patients. Next.
Slide 16. Slide.
Question 3 is that mention the expected abnormal neurological examination of the patient. Now we go for the examination because you are a clinical student. You must identify what are the abnormalities present in this patient, and this will guide you the proper treatment, whether the patient's GCS is just decreasing. So you must call a neurosurgeon, or the patient developing a new signs and symptoms or improving. So this will guide your therapeutic decision. So this is very important for a clinician. So I have mentioned the abnormality in the neurological examination of the patient. This is GCS. This is very important because if there is low GCS going on, you must have a very urgent neurosurgical consultation. Fundoscopy, you can get a papillary edema here. You can get a cranial nerve palsy 3rd, 4th, 6th, or 7th, or you can get a long tract sign or upper motor neuron sign. Now, next question is that suggest the definitive management. The definitive management is that there is an shifting of the midline together with this feature. It is a neurosurgical consultation or drainage of the hematoma or operative treatment. This goes on. Now, you can have a various diversities of the subdural hematoma. You see, first I go in this CT scan. You see, there is nothing in this. You just roll down, scroll down, down, and you see here you don't see any sulcus and gyruses, and you can see faint temporal horn of the ventricle. Now go here you can see here there is a faint area. You go there is a definite hypodense area followed by the hyperdense area below, and this is also faint, and there is no sulcus and gyruses. Just you scroll below, this is below, and there is midline shifting. Here there is midline shifting, and this ventricle is compressed. The midline shifting complex, no sulcus and gyruses are effacement, and there is hypodense followed by the hyperdense area. Is it clear? No. You search anything else? Yes. You go below. You see there is a faint hypodense area there. You see there. You see there. You see that. It is, and you see there. You see there. So this is a bilateral subdural hematoma, acute and chronic subdural hematoma. This is a bilateral one. So don't forget a bilateral one. So I have repeatedly told you that when you got, you just don't think you have got the 100%. There may be something percentage behind you left below. So always look back and see whether you have left below anything or not. In this CT scan, you see, go for it. There is below, there is go upward, scroll upward, no, nothing. But you see, nothing, the ventricles are normal. But here, you see, there is an linear sickle cell area with hyperdense area. This is called hyperdense, this is hypodense. So this is an chronic subdural hematoma. You can see the chronic subdural, and this is where you see, here there is bilateral. It's going in unilateral, coming to that of the bilateral one. So these are the bilateral. So don't forget any subdural hematoma when you encounter in the examination. Don't forget it may be a bilateral subdural hematoma.
Slide 18. Slide.
Now, second case is that study the non-contrast CT scan of the 24-year-old man who presented in the emergency department and answered the following question. I have not given like that of the question 1. I have just made the CT scan here. You go for searching it. This is the fine. This is fine. This is fine. When you come here, you look for this. This is the paracisternal area. You can see an hyperdense area here. You go hyperdense area here and here, and go below. Below there is a hyperdense area in the sulcuses. in the sulcus, and you see the sulcus and gyrasis are very prominent. So there is effacement of the sulcus and the gyrasis with that of the hyperdense areas in the sulcus and gyrasis. So the diagnosis is very obvious. It is an subarachnoid
Slide
hemorrhage.
19.
Now,
Slide.
the questions you can have. Mention the abnormality in the CT scan. There is hyperdense shadow or hemorrhage in the sulcus and gyrasis cisternus. There is ventricular effacement or obliteration, and sometimes there may be enlargement of the ventricle. Here it is not evident, but you can get the picture with enlarged ventricle and hydrocephalus. So this is very important. I have put it here. So I have put it here, but it is not in this scan. Enumerate the expected neurological sign in the CT of the CT. What are the neurological signs you can expect? Again, GCS, fundoscopy you can have, and subhyaloid hemorrhage. But when you write fundoscopy and when one writes subhyaloid hemorrhage, the subhyaloid hemorrhage will have a more score than that of the fundoscopy. Cranial nerve, third, fourth, and sixth cranial nerve palsy is very evident. There will be long tract sign, and there will be signs of the meningeal irritation or neck rigidity, Karnick signs or Budinski sign. So these are the expected neurological signs in case of the subarachnoid hemorrhage.
Slide 20.
Now,
Slide.
next question will come. They mention the causes of the above CT finding. The cause of the subarachnoid hemorrhage is the aneurysmal rupture, AVM rupture, or trauma. Trauma is one of the important causes of the subarachnoid hemorrhage, but in medicine you get aneurysmal rupture and AVM rupture. Next, enumerate the expected neurological complications of the above CT scan finding. The neurological complication of the CT scan finding may be, number one is hydrocephalus. You can have a CT hydrocephalus with that of the subarachnoid hemorrhage. You can have an rebleeding with the subarachnoid hemorrhage. You can have an vasospasm, or in fact, with that of the subarachnoid hemorrhage. Seizure is one of the important causes. Rest, ICP is one of the important causes. Hyponatremia or syndrome of inappropriate radiation secretion are the important neurological complication of the subarachnoid hemorrhage. So you must know this because you have to manage the case. This is the very important. You are not a radiologist, just you give a report and that ends. But it does not end. It ends with the patient recovering. So this is a very important one. You must identify one of these symptoms and signs. Mention the invasive or non-invasive investigation or establish the etiology. I have shown the etiology may be aneurysmal or AVM. So you can have a CT angiogram, which is a more or less important, MR angiogram, or DSA, which is the gold standard of diagnosis. So this is an invasive, this is a non-invasive. As per question, you can answer it. Mention the definite treatment. It may be surgical or non-surgical. There is coiling, clipping, and aneurysmal surgery. These three is the definitive treatment of the subarachnoid hemorrhage. So these are the possible questions you may encounter in patient with an subarachnoid hemorrhage. Now,
Slide
what are the
21.
diversities?
Slide.
Subarachnoid hemorrhage, a CT scan has a very diverse presentation. Sometimes you can't find anything because there may be a hemorrhage below. So this is a very important one. Sometimes you can have a very overt. You can see this is a very overt one. You can see when go below upward, you see there is an hyperdense area. This is hyperdense area. Both the sulcuses and are filled with that of the blood. You see, all are filled with that of the blood. All are filled with that of the blood. But you see when you compare the left and right, you see there is a more blood here than that of the opposite side, and also there is a hypodense area here. You can see this hypodense area is there, and also see there is compressed. This ventricle is more compressed than that of this ventricle. So there is additional. Don't jump. There is additional finding. This is one. You can see that. You can see there is an hypodense area along the. So this possibly this is an sulcus. In this sulcus there lies an middle cerebral artery. Possibly this is the middle cerebral artery aneurysmal rupture. Possibly you will be sure when you do a DSA. So this is a very important one. But you must identify when you write a subarachnoid hemorrhage only, you get 1 point. When you say subarachnoid hemorrhage with that of the intensity here, with that of the hypodense area here, with that of the compression of the ventricle here, so you get more marks. So these are the very important. You must not leave anything. You go in the second or B slide. When you go, you just roll out from above downward. You see there is a hemorrhage in the fissures and also in the anterior fissure, and also there is like this there is an hypodense area also, and here lies the anterior cerebral artery. So this is possibly a rupture of the anterior cerebral artery. So this is a subarachnoid. Here there is a very important thing is that there is an hemorrhage also in the fourth ventricle. So this is also extended to that of the fourth ventricle. So don't miss anything. Go from below upward or above downward and scroll every slide. This is a very important one.
Slide 22.
Now,
Slide.
there are other diversity of subject. I have told you before. This one will come. There also there you go in the cisterna. Look in the cisterna. There is a hyperdense. There is hyperdense, and also there is an hemorrhage here. This is a big slanting scan. I think you are just having a difficulty in seeing because these are all from our cases or my cases. So these are the sometimes photography is not very good. So this may have an hamper. But you see, there is additional finding. The ventricles, there is a temporal horns has been enlargement of the ventricles. So it has gotten every chance of an hydrocephalus and developing an hydrocephalus. So this is a very important one.
Slide 23.
Case 3.
Slide.
Now, study the non-contrast CT scan of the 24-year-old female with an exertional dyspnea palpitation and answer the following question. Enumerate abnormalities in the displayed. There is an abnormality. You go for. I have given only one slide. I will tell why. So there is an hypodense area. You see hypodense area, large hypodense area, or in fact there is perineal edema. There is midline shifting. This ventricle is compressed. Then that of this ventricle. There is effacement of the sulcus and gyrus. So these are the abnormal findings. There may be sometimes when you get a large hypodense area, always search whether there is any hyperdense area in between. I'll show you after that. Why? I will tell you. Mention the abnormalities in the cardiovascular examination of this patient. You see, the scenario is a 24-year-old female with exertional dyspnea and palpitation, and had a large stroke in the brain. So when you go in the stroke is ischemic and hemorrhagic. Ischemic stroke is embolic and in situ thrombus. Embolic stroke is the embolic coming from the large artery and to the heart. This patient has got dyspnea and palpitation. So you focus on the heart. Abnormal cardiovascular examination. The 24-year-old female, most common is the atrial fibrillation, and it is valvular atrial fibrillation. So mention the cardiovascular abnormality, that is irregular pulse or atrial fibrillation, pulse deficit, that you will count. You will have a tapping apex beat, you can have a diastolic thrill, you can have an opening snap, you can have a loud faster sound, you can have a mid diastolic murmur, maybe have a pre-systolic accentuation. So this goes in favor of what are the findings you determine in the cardiovascular examination of this patient.
Slide 24.
So
Slide.
I have already told that why you look for a hypertensive, large in fact can have an hemorrhagic transformation. So this is very important. Write the cerebral complications. There may be hemorrhagic transformation, there may be herniation or raised intracranial pressure due to a large impact, there may be seizure. Mention group of the drugs that prevent the above episode. This is an atrial fibrillation. An atrial fibrillation will have an embolic stroke. So we can use the vitamin K antagonist. You can use warfarin or DOAC or newer oral anticoagulant, rivaroxaban, avaxaban, or divaricate. Mention the definitive treatment if the patient deteriorates and failed medical. Sometimes you can have an large infarct in the middle cerebral artery territory. We call it a malignant MCA. It may not be related to the atrial fibrillation, or it may be related to the atherosclerotic carotid disease. So sometimes you need a decompressive craniotomy. So enumerate the rationale to prescribe the preventive measure of the such episode when there is an atrial fibrillation, especially in case of when you see the scenario to that of the adult. You must have the things that are non-valvular. This is a valvular atrial fibrillation, and this is a non-valvular atrial fibrillation. You have to prescribe the anticoagulant depending upon the CHAD A to D VAS score. CHAD VAS score, that is you can have a cardiac failure, hypertension, age below 65, above 65, diabetes mellitus, history of the TIA or stroke gives 0.2, vascular, that is the peripheral vascular disease or aortic atheromatous disease, and sex, female sex. So this score, it sometimes asks or in the examination, and patient may and examiner may have to give you the treatment depending upon the scoring. So this is a very important score you must remember as a general medical specialist.
Slide 25.
Now,
Slide.
you see here, you go on this slide, This is an more or less. You see, apparently you see nothing. When you just probe deep into it, just go here. You see there is an hyperdense area here, not here. I have enlarged it. There is an increased hyperdense area. This is called a hyperdense MCA. That is a very early feature of the stroke, and this is an occurring. The stroke is evolving here. This is an evolving stroke here. You may have the questions in your book or in your OSPI other examination, that is how you will manage this if the patients come within the 3 hours. So this is an endovascular treatment of the acute ischemic stroke you can have, and you must identify the hyperdense MCA is very important sign. Hyperdense MCA very important sign, and middle cerebral artery always lies in the fossa, so it has got a definite anatomy. So hyperdense MCA is very important to determine the early stroke, because you can have an interventional treatment of an early ischemic stroke.
Slide 26. Slide.
Now, what are the diversities you can have? You can have the scan in the in fact in the occipital lobe, and the frequent question will be asked or is that how you, if there is a stroke here, what will be the problem in the eye, or what will be the visual? When anyone gives clue visual, you get the clue. When anyone gives what we'll get in the cranial nerve examination, then you get a bit confused. If this is an homonymous, you will get a homonymous hemianopia in this case. There is an hypodense area in there. This is a cerebellar stroke. So cerebellar stroke, you can be asked for the features of the cerebellar stroke, or say features of the cerebellum involvement.
Slide 27. Slide.
Now, the scenario: a 50-year-old man presented in the emergency with vomiting and tendency to fall on walking. His MRI is displayed. Study the MRI and answer the following questions. This is a very important one. I have given only one because of the time constraint, because whole of the MRI scan. So there you can see an hyperintense shadow here. This is a medulla. This hyperintense shadow here. This is a fourth ventricle. So this is cerebellum. So this is a medulla here. This is systole, this is the medulla here, and there is hyperintense shadow. This is on the lateral medulla. So this is a lateral medullary syndrome. So what are the abnormalities in the motor examination of this patient? On the side of the lesion, you get nystagmus and diplopia. So you always, lateral medullary syndrome presents to you with diplopia, dysphagia, dysarthria, drooling. You just 4D, you remember this 4D: diplopia, dysphagia, drooling, and dysarthria. There is nystagmus. So there is paralysis of the soft palate. When you examine the soft palate, you see the clogging of the saliva and diminished gag reflexes. There may be partial ptosis due to sympathetic Horner syndrome. So, and there is decreased sweating. There is imbalance or ataxia of the limb due to cerebellar peduncular involvement. And also there is an involvement of the weakness of the left on the same side of the tongue if there is involvement of the medial side of the medulla, and weakness of the arm and the leg, increased reflexes when it involves the medulla. I have included these two here as a complete medullary syndrome, and this up to this is a lateral medullary syndrome, and this too is the medial medullary syndrome, just to give a run off from the time. Now this is the full MRI. You see, full MRI will go from the down upwards to the down. You see, this normal. When you come here, you see this is a complete medullary. This one, you see, this is a complete medullary that has got. When you are given a whole film of a lateral medullary, and if it is a T2 image, it is very difficult, and if it is a DW image, it is very easy to identify. So, but what image will be given? You don't know. I don't know.
Slide 29.
Now, 5 scenario. Study the non-contact CT scan of the head of the 48-year-old hypertensive male and answer the following question. You see, you go for this. You go from above downwards. This is nothing. This is nothing. This is nothing. Going on. When you come here, there is an hyperdense area followed by the hypodense area in the cerebellum. You see, there is cerebellum. These ventricles are enlarged. You see, when you go also, the ventricles are also enlarged. So this is a cerebellar hemorrhage. Mention the abnormalities in the CT scan: hyperdense or hemorrhage on the left cerebellum or the right cerebellum, anyone. Hypodense or perilesional edema is there. Compression, there is, you don't see the fourth ventricle, so there is compression of the fourth ventricle. Mention the expected neurological sign in this patient. You get the cerebellar sign: nystagmus, dysarthria, intention tremor, past pointing dysarthria, dyssynergia, rebound phenomena, Hilshin test, ataxia or imbalance. You can get. So these are the cerebellar sign. But beside this, you get the other neurological sign also. That is GCS is very important one, and signs of the rest ICP, papilledema or cranial nerve palsy, because you have to follow up this case because it may need a neurosurgical consultation. You are the responsible for all of it. So diversities are key. What are the diversities? You see here, there is an hypertension. This is the thalamic hemorrhage. This is the very common thalamic hemorrhage. You may ask, you may ask for the sensory changes in the patient of this thalamic hemorrhage. Here, this is the hemorrhage in the basal ganglia. This is a basal ganglia hemorrhage. You can ask for any involuntary movement and other movement disorders regarding these CT scans with other findings.
Slide 31.
This is a cerebellar hemorrhage, but don't. I have already told, don't jump. You see, this is cerebellar hemorrhage, but you see there is also another hemorrhage. There is also hemorrhage in the third ventricle. There is also hemorrhage in the just in the occipital horn of the lateral ventricle, of bilateral occipital horn of the lateral. So there are multiple hemorrhages: cerebellum, also here, also here, also in the ventricles. So multiple. So in this case, you must ask for the patients with that of the hypertension and also taking of the antiplatelet drugs. Antiplatelet. This patient was taking double antiplatelet drugs. So the antiplatelet drug, also anticoagulant, is very important. Here in this slide, you can see there is a hyperdense area. With that of it goes into the ventricle. There is also ventricle and compression of the ventricles and shifting of the midline. So this is another one.
Slide 32.
This is another diversity. You can see, you can have the hemorrhage here. You can have the hemorrhage here with that of the enlargement of the ventricle. The temporal horns are seen. Here also there is a very large hemorrhage, and this is a very atypical one. When there is a atypical one, what we will do, I will show you later on.
Slide 33.
This is a pure hemorrhage within the ventricular system. This is a primary intraventricular hemorrhage. This is a primary intraventricular hemorrhage. So this is one of the important characteristics of the hemorrhagic. So I have already shown the various hemorrhages you will encounter in the CT scan.
Slide 34. Slide.
You go in this CT scan, this patient presented to us with that of the acute confusional state. You see, we go below, upward, nothing. But you see, there is an effacement of the sulcus and gyrus is not clearly seen. When you go here, you see there is a linear shaped hyperdense area here. Hyperdense area, a very atypical. This is a parasitical area, very atypical area in the cortex of this man, and this is an atypical area. When there is any atypical hemorrhage beside thalamus, beside internal capsule, beside pons, beside cerebellum, you must inquire about it. So we inquired about it, and we have done a brain scan with that with CTA, and we have found that there is an atriovenous malformation here. So don't forget it. The question may come, what are the investigation you do if there is atrial fibrillation, atriovenous malformation patient, and it is a cortical one, patient can present with a intractable seizure.
Slide
Don't
35.
forget it.
Slide.
Sometimes hemorrhagic stroke has mimics. So what the mimics? You can see this is this one. This one is not inside this epidural hematoma. It is not, because but you see that is a dural tag. It is continuous with that of the dura. So this is an meningioma. In this, you see, go up, nothing. But there is an hyperdense area. There is an hyperdense area with midline shift. This is a midline shift. The hyperdense, this is a very irregular one. This is a very irregular one. But when it comes, it has a very definite shape. This is a definite shape. So it conforms to that of an hematoma.
Slide 36. Slide.
The study the CT scan of the 45-year-old male and answer the following question. Mention the abnormalities. You see the abnormalities. I have told that a hyperdense area with hemorrhage, periodicial edema, and there is also blood in the ventricles, and there is compression. Enamours the point in the history to highlight the above finding. Hypertensive bleeding is very important. Hypertension treatment or irregular treatment, headache, neck pain, vomiting, confusional state, and loss of the consciousness. This is very
Slide
important one.
37.
Mention the
Slide.
cerebral complication of the above case. This case will have a raised intracranial pressure. There may be obstructive hydrocephalus. There may be hyponatremia, and there may be low GCS. Is very important. Give general management. There may be point 1, 2, 3, 4, 5. Airway, breathing, circulation, very important. Maintenance of the nutrition, bladder and bowel and mouth care, prevention. This is a basic medical question. DVT, prevention, and chest physiotherapy. Because as a medical graduate, as a medical specialist, you must manage the both specific and general. So you have to touch both two. You have to jack of all trade.
Slide 38. Slide.
The question 7. Studied on contrast CT scan head of a 30-year-old female present with fever, recent onset of the headache, and weight loss of the 20 kg in last 2 months. Answer the following question. When you go, this is a contrast CT scan. As shown, there is a contrast enhancement. There is a contrast enhancement with this. So there is hyperdense ring, inner shadow surrounded by the hypodense. This is hypodense area with perilesional edema. There is a huge edema. There is edema in the both hemispheres. There may be where there is situation. The ring is hypodense in the center. The rim of the ring is regular or irregular depending upon the which you have seen. This is a regular one more or less, and there may be ventricular effacement or enlargement. What you find, you just write it down. Mention the differential diagnosis of the above CT scan. There is a ring inner shadow, so it will be multiple tuberculoma, multiple abscess, cerebral cystosarcosis, multiple secondary toxoplasmosis, and CNS lymphoma. These are the differential diagnosis.
Slide 39.
Now,
Slide.
mention the other points in the history that you look for the reach a diagnosis. So you see the contact, I have tuberculosis, so contact the tuberculosis patient, or history of the past tuberculosis with incomplete treatment, history of the local or systemic infection, that is abscess, contact with the pig, dog, or occupation, that is a cerebral cystosarcosis, sexual exposure or blood transfusion or intravenous drug abuse also goes to the abscess, and HIV. Swelling of the any part, because toxoplasmosis is usually associated with that of the HIV. Swelling of the any part of the body, that's lymph node enlargement or any primary or secondary. So these are the things you write and the points in the history. Enumerate the abnormalities in the general examination of the patient. Sometimes you can ask it, because generally you can have an anemia, you can have a lymphadenopathy due to secondaries, and also a skin nodule of the secondary. There may be clubbing in case of the if there is an bronchogenic carcinoma, or clubbing may be due to a lung abscess which has metastatized to that of the brain. Also, there may be clubbing in the subacute bacterial endocarditis. Patient may have an metastatic abscess in subacute bacterial endocarditis in brain. Enumerate the non-invasive investigation to presume the diagnosis. So you have content the differential diagnosis. So you go for the other diagnosis. PET CT is one of the important investigation in this arena to determine the primary focus where
Slide
it is.
40. Slide.
So there is multiple. There may be diversities. There may be multiple areas of the ring in and shadow everywhere in the brains.
Slide 41.
Case 8, a 30-year-old male present recently developed hypertension and diabetes mellitus with blood sugar 14 millimole, complaining of the visual disturbance in both eyes. His MRI of the brain is displayed. Study the scan and answer the following question. Enumerate the expected abnormal finding in the examination of the cranial nerve. We have not gone for any of the scan finding. Just enumerate the expected normal findings, abnormal findings. You see, there is an area. This is, you can this is a sphenoidal sinus. Just above the sphenoidal sinus, this is increasing into the brain. So reduced. So this is an pituitary tumor is extending upward, compressing the optic chiasma. So there is a reduced visual acuity, near or far vision, visual field defect, or bitemporal hemianopia, or upper quadrantum. There may be decreased apparent light reflex. This is very important. Optic disc may be pallor. There may be visual vessel count will be reduced. There may be ocular nerve, 3rd, 4th, and 6th nerve palsy, or because of the involvement of the cranial nerves. Here it only you can have a mini slide where you can see the infiltration of a tumor into the cavernous sinuses. So I have made it here. It is not evident in this scan.
Slide 42. Slide.
Mention the other biochemical investigation to reach the diagnosis. This is an pituitary tumor and this is the macroadenoma. So what are the biochemical? So serum thyroid function test, T3, T4 and TSH with serum prolactin, serum sex hormone test, LH, FSH, gonadotropins, serum testosterone because this is a male, serum IFG level, IFG1 that is a growth hormone, IFG level is very sensitive, or you can have an insulin induced or stimulation test. Growth hormone levels during oral glucose tolerance test is one of the important tests for determination of the growth hormone levels. So this is the test we can have a biochemical test. In a the treatment modalities. So you can have various modalities of treatment. I have written it. It may be medical. You can give bronchyptin or cabergoline. You can give somatostatin therapy. You can give growth hormone receptor antagonists. They are found in the name of the tebizomate, or you can write growth hormone receptor antagonist. There may be surgical resection or transspinodal or stereotactic or gamma knife surgery. There may be sometimes there may increase the radiotherapy. So medical, surgical, and radiation. You can you may be asked any one of the treatment modalities you choose depending upon the marks given.
Slide
The
43.
diversities is that you can have a pituitary tumor in the CT scan like this. You can have this in this, and you must see this is whether there is compression of the nerve and whether there is infiltration of the cavernous sinus or not.
Slide 44. Slide.
Just we go to the other cases. A simple, I'm nearly end of my topic. Or lecture. The scenario: a 55-year-old male presented with the imbalance. Study the displayed CT scan and answer the following question. He presented with the imbalance. So you see, when you go for the CT scan, you go here. Just you go, you see there is an hypertension area here, paracalvia. You go upward, you see the ventricles are enlarged. Ventricles are enlarged. These ventricles are enlarged. This hypertension area near coming to the ventricle. This hypertension coming to the ventricle. This ventricle. The ventricles are enlarged. This is ventricle. So this is a shunt given with enlargement of the ventricle. So the question may come, enumerate the abnormalities in the CT scan. So there is a shunt placement here. Enumerate the complaints of the patient. The complaint was this is possibly he may have a normal pressure hydrocephalus for which the shunt was given. So the complaint of the patients may be that number one is the dementia or forgetfulness or decrease in the memory. Number two is urinary incompetence. These two is very important. And number three is the ataxia. And mention the abnormality in the neurological examination. So when you get ataxia, you must have a tandem walking test of this type of the patients.
Slide 45.
Test 10.
Slide.
Study the non-contrast CT scan of the head and answer the following question. You see there is a non-contrast CT scan. You see bilateral hyperdense shadow is just mimicking that of the calvarium or bone. So this is the calcification. So bilateral calcification of the head of the caudate nucleus. This is the internal the head of the caudate nucleus and also globus pallidus and others. So internal capsule and also the caudate nucleus calcification. Abnormal hyperdense lesion in the both basal ganglia. Sometimes you can have a cerebellum when you have the whole of the picture of the brain CT or lobes of the brain. Bilateral basal ganglia calcification. Enumerate the finding of the neurological examination. You can get papilledema here. Involuntary movements because it's a basal ganglia involvement. So involuntary movements of the various kind, dystonia, dyskinesia, tremor, and other hyperkinetic movement disorder or hypokinetic movement disorder can accompany this. Mention the cause of the above abnormality. The bilateral basal ganglia calcification may be into the primary hypoparathyroidism, maybe in the pseudo hypoparathyroidism, maybe idiopathic, or maybe in the first disease.
Slide 46.
I am nearly at the end of my presentation. Though I have intention to do the CT scans and I have covered, I don't know how much, but in a single lecture it is very difficult for covering all of the brain. Now, last slide. The 24-year-old female presented with the sudden onset of the visual loss of his right eye, with pain on movement of the eye. You follow the visual loss, sudden onset, pain on the movement of the eye. Followed 2 days after, he developed weakness of all 4 limbs. He studied his her displayed cervical MRI sagittal section and answered the following question. When you displayed, you see the sagittal MRI has been displayed and you see there is a longitudinal extensive hyperintense shadow here. This is CSF white in brain T2 image, and this is an hyperintense shadow in long. This is a longitudinally extensive transverse bilitis with that of the pain in the right eye movement of the eye, pain on the right eye movement. So enumerate the abnormalities in the MRI. Hyperintense shadow, more than 3 segments. This is very important. Hyperintense spinal cord, shadow in the spinal cord, more than 3 segments is very characteristics of a disease. I told you. Mention expected abnormalities in the examination of the second cranial nerves. So the patient has got pain in the right eye and on movement. This patient presented to us in just before the corona, that is in last February, in 5 February 20. And it was referred to me by an ophthalmologist because he presented with weakness. He could not mention it. Expected was the eye examination reduced visual acuity, near and distant vision. Loss of the color vision is very important because early it will go on. Dilated people and relative apparent people are light reflex and optic swelling. You can get an optic swelling in these cases.
Slide 47.
Enumerate the other expected neurological finding in examination of the limbs. When there is an quadriplegia, you can get that is an spinal cord lesion. You can in spinal cord lesion you get motor, sensory, and autonomic feature. So motors you can get of the weakness, hypertonic or spastic, absent or DTR if it is a spinal shock, or increased DTR, deep tendon reflexes. If the shock is not there, the plantar will be extensor. There may be clonus. Sensory, there may be sensory level. Up to certain whichever you determine. Loss of the pain or touch and temperature, bladder involvement or autonomic involvement. These are the neurological, expected neurological in case of the quadriplegia or paraplegia of spinal cord lesion. Mention the immunological blood examination. This is very important because this is a longitudinal extensive transverse myelitis, and with that of the involvement of the eye, that is this is involvement of the eye together with that of the spinal cord. So this is an aquaporin 4 IgG antibody or anti-MOG antibody. This is basically this is an immunologically mediated central nervous system disease. 3 immunologically mediated central nervous system disease is very important. Number 1 is multiple sclerosis. Number 2 is NMO spectrum, which covers aquaporin 4 antibody disease, anti-MOG antibody disease, and secondary to that of the SLE, to that of the antiphospholipid antibody syndromes, and also the sarcoidosis. So we can have the immunological test of the aquaporin 4 antibody, anti-MOG antibody, ANE screening, or anti-dsDNA, serum ACE level antiphospholipid antibody. This is more or less common in our entity in our Southeast Asia than that of the MS. So it can be given. I have to mention one thing here. In case of the optic nerve involvement in these 3 immunological disorder have a very distinct feature. Multiple sclerosis is the primary CNS immunological immune disease, or aquaporin 4 antibody disease, and anti-MOG antibody disease. When there is question of the optic nerve involvement in multiple sclerosis, multiple M, middle, you put it in the middle. Multiple sclerosis will have a optic nerve involvement in the middle. You can get hyperintense shadow in the middle of the optic nerve. This is very important. After AM, it comes in. So NMO or anti-aquaporin 4 antibody, it goes into the posterior. It will cover more than 50%. And MOG, left one, MOG will be an anterior. So there will be anterior hyperintense shadow here, more than 50%. And in case of the MOG antibody disease, you will get an optic disc swelling. So this is a very important differentiation. You can go for the MRI. Not doing this test, it can come 5 to 7 days before, and you get the MRI on the bedside. So this 3 is very important point to distinguish between the autoimmune disease of the central nervous system with multiple sclerosis, MOG antibody disease, and aquaporin 4 antibody disease. Last question is that name one drug with the route of the immediate management of the above disease. So this is an longitudinal extensive transverse myelitis. So methylprednisolone is the drug of the choice. When the patient does not respond to the methylprednisolone, you can give IVIG or plasmapheresis. So this is the acute treatment of the devastating autoimmune disease of the central nervous system. So I have included here. Lastly,
slide 48.
Don't be panicked. Just scan, read and scan from above downwards and below upwards. Look identity of the both sides. Some in the front, in the middle, in the back. Give 2-side identity. Look for any abnormal enhancement. This is a very important one. Correlate the pathology and the anatomy, which is you think which of the pathology may be. You just think of the vitamin. It is a vascular, it is infective, or it is autoimmune, or it is a metastatic, or it is a tumor. Density and mass effect. Don't forget to see the mass effect. That is compression of the ventricle or enlargement of the ventricle or anything. With this, I end.
Slide
With this,
49.
I think it has become a boring to you, but I tried to cover. It's a vast subject, and within one lecture, it is very difficult to cover. I just apologize for the just not covering all, because it is not possible to cover all. So if you benefit, then we wish all of you best. Thank you very much.
ধন্যবাদ স্যার আপনার মহামূল্যবান প্রেজেন্টেশনের জন্য। এই পর্যায়ে আমরা চলে যাব কোশ্চেন অ্যান্সার সেশনে। ফেসবুক বা ইউটিউব লাইভে পাওয়া কমেন্ট গুলোই আমরা স্যারের সামনে উপস্থাপন করব। এই পর্যায়ে আমি ডক্টর শর্মিষ্ঠা ম্যাডামকে অনুরোধ করব কোশ্চেন অ্যান্সার সেশনটিকে শুরু করার জন্য। ডক্টর শর্মিষ্ঠা ম্যাডাম।
Thank you, sir, for your wonderful speech. In the meantime, we have got some queries. Some questions were put by Dr. Maisum Sobhan. Her first question is, how can we differentiate old hemorrhagic stroke from ischemic one? What is the preferred investigation to differentiate the both things? Thank you, sir.
আমি তো অনেকক্ষণ কথা বললাম, আচ্ছা স্যারই বলুক, স্যার আছে যখন, তখন স্যারের কাছ থেকে সবাই শুনতে চাই।
বলো কুরাইশি বলো।
স্যার আপনি বলেন স্যার।
আরে বলে বলো।
Actually, basically, old hemorrhagic stroke. I have told that the hemorrhagic stroke has various stages. It go on. Hypodense, so that the hyperdense, so that the isodense, and sometimes it is very difficult to differentiate old hemorrhagic stroke from the ischemic stroke. I have an intention to cover it up, but acute stages are very important. The thing is that you see, it is more or less, it goes on the gliosis and others, and the density is become more or less like that of the, it goes with that of the water. There's a very important one to that of the CSF, and you can see it may have an tractional effect. You look at the ventricles, see on the periphery of this lesion, you get the traction of the ventricle, and the ventricle of the side is dilated, and with that of the site of the hemorrhage is becoming more or less the like that of the or water like, that the CSF like density. So these differentiate from the acute or a subacute ischemic stroke to that of an old hemorrhage.
Yeah,
thank you, sir.
So Quraishi, I would like to add one thing with you.
Sir.
Yeah, two things. This is a very important question, I think so, because
yes, sir.
Many times there could be little difficulty to differentiate between infarct and the chronic hemorrhage. You see, all the hemorrhages are usually left in infarct. All the hemorrhages. If you see a hemorrhagic stroke patient after 2 months, when you go for the CT, you will see an infarct. But that infarct is little bit different from the ischemic infarct. In one point, that infarct is maintained around the structure, does not maintain the real periphery of the blood vessel. But if the ischemic stroke, that usually maintain vascular territory. This is one of the added points along with the calculation. Thank you.
Thank you, sir. Sir, our next question, second question is, if a patient comes with the features of acute ischemic stroke, where the thrombolytic therapy is preferred within 3 hours, then which one should be preferred, CT scan or MRI?
First thing is that for thrombolytic therapy, CT scan is preferred, because time is the brain, number one. When you see, I have told that you go for the CT scan and you look for the CT scan very intensely. CT scan is a very urgent investigation. You can do it within minutes, and you can prepare for the thrombolysis. And the main aim of the CT scan is that you just exclude the hemorrhage. In case of thrombolysis, you exclude the hemorrhage. When you see in the CT scan hyperdense MCA, so in that case you can have an thrombus there, so you can have to go for an further investigation to go a CTA to determine whether if there is any thrombus there or not, or a DSA, but this is default, but CTA is preferred. Go for an intravascular thrombolysis or that is the intraarterial thrombolysis, or together with the intraarterial thrombolysis with mechanical thrombectomy in case of a large middle cerebral artery or a internal carotid artery stroke. But on the other hand, if you go for a thrombolysis therapy, CT scan is enough, because you go and it is a very easy investigation to do, and time is a very important thing. So these two is very important.
Thank you, sir.
I'd like to add again, because the question is, I tell you that the non-contrast CT is the first investigation in all cases of acute stroke. Non-contrast CT is the first investigation for all types of acute stroke, because it is not only for thrombolysis, but in all cases of acute stroke, non-contrast CT is the first investigation.
Thank you, sir. Sir, another question by Dr. Muriam, Dr. Maisum Subhan. How can we differentiate hemorrhage with perilesional edema from infarct with hemorrhagic transformation?
Hemorrhage with perilesional edema, when there is an edema, it will cross the vascular territory. This is very simple, and it is above the or surrounding that of the H. In case of an hemorrhage within an infarct, the infarct has a definite shape and size, and the hemorrhages are within it, and you can see the hemorrhages in the sulcus and gyrus within the core of the infarct. I have shown you the slide, if you remember, that the hemorrhage within the infarct looks within the infarct, it is hemorrhage, and it is hemorrhage, and when there is perilesional edema, it is a hypotenuse. With that often within a hypotenuse with that often hemorrhage that surrounds the hemorrhage. This is the main difference.
Thank you, sir. So our another question done by Dr. Shajib Ahmed: how to differentiate intraventricular hemorrhage from calcification?
I see the question now. How do you differentiate IVH from calcification? IVH is the calcification of the intraventricular hemorrhage. When there is hemorrhage, the main is the appearance. Appearance is like that of the hemorrhage, and calcification is more whitened to that of the more bone. Number two is that hemorrhage is when you get the hemorrhage, it will settle down the ventricles. So you can get a settle down in the ventricle with that of fluid level. Yeah, but calcification is just it hangs in the ventricle. So these are the two differences, and this is an homogeneous calcification is an homogeneous one, and the hemorrhage within the ventricle may be heterogeneous because of the time differences of the liquidification of the hemorrhage. So these are the three differentiation.
So thank you, sir. This is our fifth and last question. What are the basic points to differentiate a CT film from an MRI? Sir, what are the basic points to differentiate a CT film from a MRI?
These two are the basic thing is that CT, you see that it's bone. Bone is MRI does not pick up the bone. So CT can pick up the bones. So you see the bone. The bone is hyperdense and it is white in all of the. MRI has a various sequences. So you see the films of the MRI with the various sequences such as T1, T2, FLAIR image, DW image, GRE image. So they all give the different views. So you can compare the different views with that of a single view. CT scan have a view that is an axial section, coronal section, and the sagittal section. So they have a bone. So bone is very important. Bone density is very important here to differentiate from the CT scan and the MRI. Yes.
Thank you, sir, for your wonderful presentation and discussion. As we have time constraints, we are not taking any further queries. Our next program will be on the next week, on 12th November 2020, where we shall learn about upper GI endoscopy from Professor Ahmedul Kabir, Professor of Medicine, Dhaka Medical College, and the Secretary General, Bangladesh Society of Medicine. So dear viewers, now I would like to request Professor H.A.M. Nazmul Hassan, Governor ACP Bangladesh Chapter and former President, Bangladesh Society of Medicine, for his comment.
Dr. Sharmista, Dr. Prince, am I audible?
Yes, sir. Yes, sir.
Yes, sir, you are.
Assalamu alaikum and good evening. Thank you, Dr. Sharmista. This is definitely a rare moment and rare opportunity. In a single frame, we are getting three very renowned physicians, clinicians, medical educationists, and experienced clinicians and mentors in one frame in a single moment. Professor M.A. Jalil Chaudhry, Professor Kajiuddin Mohammad, and Professor Firoz Ahmed Qureshi. All of them are senior to me and very loving to me. I respect all of them. Regarding this program, Dr. Sharmista, she has mentioned that this is organized by American College of Physicians Bangladesh Chapter and supported Bangladesh Society of Medicine. The main objective of this type of health talk, additional talk, is to help the resident physicians and junior doctors and graduate doctors and early career physicians. They are the future of our country. That's why we are going to arrange this sort of program. During the last week, we had a presentation on medical ethics by Professor Kazi Tariqul Islam. Hopefully we will continue this program. Regarding today's topic, neuroimaging, this is a huge topic. At first, I must congratulate Professor Firoz Qureshi for his wonderful presentation. Within 1 hour, he has tried to cover many things. Although we have some ideas like neuroimaging, but this is a huge topic. There are different diversities. Sometimes we advise different in laboratory investigations, but sometimes interpretation is sometimes very difficult, and every day we can learn. Today, this is a rare opportunity. Professor Kajiuddin Mohammad, he is the renowned neurologist of our country, not of our country, he is internationally reputed neurologist. He is professor of neurology, and he is director of NINS, and he is president Bangladesh College of Physicians and Surgeons. আমি যদি একটু বাংলায় বলি, আমার নিজে ব্যক্তিগতভাবে আমি যদি বলি যে আমি কেন মেডিসিনে ঢুকলাম, আমি বলবো যে আমি দুইজনকে দেখে ঢুকছি। একজন হলো প্রফেসর M.A. কাদরি, আরেকজন হচ্ছে প্রফেসর কাজিউদ্দিন মোহাম্মদ। আমরা যখন থার্ড ইয়ারে পড়ি, আমার প্রফেসর কাজিউদ্দিন মোহাম্মদ he was doing intern under Professor M.A. Kadri. So we were observing his knowledge, attitude, and mode of talking, and that's why we followed him as a mentor. And many of medical specialists, they have chosen this subject, seeing these mentors like Professor N. Islam, Professor M.A. Professor N.I. Khan, and Professor Kajiuddin Mohammad, and another Professor M.A. Jalil Chaudhry. He is our guardian. He is senior to us. He is founder, secretary, and past president of Bangladesh Society of Medicine. So this is a rare moment, and so we want to continue this type of program in future as well. And this is done from a platform, and Dr. Sharmista, he is also secretary to our chapter. I am also thankful to her, and also Dr. Prince, he is IT associate of our chapter. So I want to express thank to Professor Firoz Qureshi again for taking the trouble and giving this time for your wonderful presentation, and Professor Jalil Chaudhry, Professor Kajiuddin Mohammed, and I also invite you to for our next presentation during on 12th November next week on Thursday at night at the same time to listen to our topic. Thank you very much, Dr. Sharmista. Over.
Thank you, sir. Learned listeners, at this moment, I feel honored to mention the name of our today's special guest, Professor Kajiuddin Mohammed, the renowned neurologist, Professor of Neurology and Director, National Institute of Neuroscience, and also the President, Bangladesh College of Physicians and Surgeons. I request sir to say a few words about our program.
Yeah, thank you, Dr. Sharmista. Good evening and assalamu alaikum, everybody. What a wonderful lecture from Professor Firas Quraishi, where he mentioned, I think, every aspect of CT scan in neurology. Before I go to my talk or comment, I would like to extend to the chair, Honorable Chair, Professor Jalil Chaudhry, respected Professor Nazmul Hasan, Governor ACP, and respected Dr. Sharmista and the audience. I feel very proud and privileged to be here in this night to join in the very important session of neuroradiology in the diagnosis. You see that neuroradiology is a very important key in investigation for neurological diseases, diagnosis of neuro diseases, and where we use the CT scan and MRI. But remember, the CT or MRI, one cannot be replacement of the other. This is very important. And these two are different in mechanism and indication and sensitivity. There are certain situations where we prefer the CT scan. There are certain situations where we prefer the MRI. The CT is usually preferred to look for the hemorrhage or any calcified lesion or any bony lesion. That means CT is good for hard tissue and MRI is good for soft tissue. Because these two differences have got explanation, which I do not want to explain really. So when you look for the soft tissue lesion, you prefer the MRI. When you look for the hard tissue, you go for the CT scan. But remember, no investigation, CT or MRI, is complete unless you go for contrast enhancement. Without contrast, neuroradiology is always incomplete. And Professor Quraishi has, in first slide, has mentioned that we go for three sections. One is the axial, coronal, and sagittal. Why you go for these three sections? We go for these three sections for three purposes. One, to localize the site of lesion. Two, to see the extent of lesion. And three, to an extent, to see the nature of the lesion. Because of three dimensions, you can see a lesion in different ways. In the axial one, actually, it's good for comparison of the both sides. When you need to compare left and right side, the axial fixture is very good. And that also is important for see the gray matter and white matter distribution. In the coronal one, this is very important for look for gray and white distribution, gray matter and white matter distribution. And also the longitudinal arrangement of the fiber tracts, longitudinal from cortex to going down. This is also important. In addition, compare, you can see the gray matter, the white matter, and the longitudinal fibers from the cortex going down. And in the sagittal section, you can see the extent of the lesion from top to downward. So these three, you will see the CT scan, they always give the three views because to know the size, extent, and the nature of the lesion. This is very important. The next one is thing that When you look at the city, what are things that you actually need to look? You look when the city looks normal, you cannot see anything abnormal. What is the impression that you might have? Are you missing something? Or you cannot see anything? If a city is normal, particular examination, normally in examination, normal city is not used. The city which is usually pathological, usually given. Usually, this is the rule of examination. But when you say city is normal, then you must look for very small blood in the fissures, very small, very minimum subaqueal hemorrhage. That is very difficult to do. One, very linear conic subdural hematoma. That Professor Qureshi has shown you different pictures of subdural hematoma. When it is very isodense with the gray matter, that if it is very linear, very difficult to differentiate. So very linear, very thin rim of conic subdural hematoma, which is isodense with the gray matter, that might be overlooked. The next one, very, very faint hypodense shadow, very early stroke, very faint, very difficult to differentiate from the other side. So whenever you see a normal city, look into the substance very carefully, look into the periphery very carefully, and look into the salsa and diarrhea very carefully. Is there any blood, or is there any isodense shadow, or is there any asymmetry between the density of the two hemispheres, one right and left? That will give you a suspicion, because in early stroke, the city can be normal. That is actually kept in mind. And finally, if there are lesions in the infratentorial region, like brainstem and cerebellum, that may not be properly picked up by the CT in normal CT. So whenever you look into a normal CT, you can go into the looking into these things. Next, whenever you see a hyperdense shadow, Professor Qureshi has showed you many slides that whenever you see a hyperdense shadow, that is blood. That is blood. Okay? And if it is more hyperdense, looks like a bony shadow, that is calcification. That is calcification. And whenever you see a hypodense shadow, it is usually infarct or the edema or the fluid. But remember, as I mentioned, that no investigation is complete unless you give a contrast, which is very important. So contrast enhancement always indicates there is breakage of blood-brain barrier. I repeat, contrast enhancement of lesion indicate there is breakage of blood-brain barrier. And this breakage is usually found in infective lesions, in inflammatory lesions, in tumors, particularly malignant tumors, and in trauma. So whenever you see a CT or an MRI, you first compare both sides. If it looks normal, then go to the periphery, and then you go down. But if you see a lesion, characterize the lesion, hyperdense or isodense, or hypodense. And depending on this character, then contrast enhanced or contrast not enhanced. So I think Professor Qureshi has described in detail all the possibilities. Not only that, he also mentioned the important questions related to the scenario. So you see, along with the radiology, he has invited many questions and he has given examples, very good examples. I think you should carry all the examples in your mind and go and practice. Go and practice. So that is how you will learn. With this few words, I would like to conclude again my profound thanks to Professor Qureshi for a wonderful and brilliant lecture, which really I enjoyed. And I will thank Professor Nazmul as the governor of SCP for organizing this kind of academic session. I must thank Dr. Sharmista for conducting the session, and I must thank the young doctor, whom I forgot the name. He's a very promising doctor, very lively doctor. I saw his very promising nature in its face. With all these, again, thanks everybody for enjoying session and giving me the time. I rather conclude my speech with many thanks. Thank you very much.
Thank you, sir, for your excellent explanation of the very minutes of brain imaging. Dear viewers, we are almost at the end of our session. And at this moment, I'd like to request the chairperson of today's program, Professor Muhammad Abdul Jalil Chaudhuri, former president, Bangladesh Society of Medicine, and former chairman, Faculty of Medicine, Bangabandhu Sheikh Mujib Medical University, to conclude today's session.
Thank you, Dr. Sharmista, for your excellent conduction of the program. I must thank Governor ACP Bangladesh chapter for inviting me to listen to this very important presentation and share this. To see the two distinguished neurologists of this part of the world, along with a few internists, and of course, my favorite dear students present in this occasion. I think those who missed this program, they missed many things. Among them, I am also a part because I couldn't attend the first half of the program. And I have nothing to say regarding the contents. One thing I have seen that it has created many enthusiasm among the students because the questions were very intellectual. That is why I think that the presentation was also intellectual and the student could understand and they put a very intellectual question. I think yesterday or day before yesterday, someone was talking that neurology is a very hard topic or subject. Then I asked, did you attend any class of Professor Din Mohammed? Well, no, sir. Then I say, that is why you are telling that neurology is hard. If you could attend a few of the class, at least one class, so you should not say that neurology is hard. The quality of Din Mohammed is that he has created his followers very rightly. Many of the role models of us, many of the senior teachers could not make the followers exactly. But the one of the many qualities of Din Mohammed is that he has created his followers. And two is one followers present Professor Firas Qureshi. And there are so many, not only. There are so many followers of Professor Din Mohammed. So I think I should end here by thanking all the, I think the team best, Professor Din Mohammed, speaker, Professor Firas Qureshi, ACP Governor Bangladesh, Dr. Sharmista, and at last, not the least, our beloved students who are in this program. Thank you all. Over to Dr. Sharmista.
Thank you, sir. So we are ending the program here. Thank you.
আমরা অনুষ্ঠানের একেবারে শেষ পর্যায়ে চলে এসেছি। এই পর্যায়ে আমি স্যারদের অসংখ্য ধন্যবাদ জানাই তাদের মূল্যবান সময় থেকে কিছু সময় আমাদের দেওয়ার জন্য, এবং আমি যারা উপস্থিত ছিলেন, যারা দর্শক ছিলেন এবং যারা প্রশ্ন করেছেন তাদেরকে অসংখ্য ধন্যবাদ জানাই। এভাবেই আমাদের সাপোর্ট করে যাবেন। আর আজকে আমরা স্যারের কাছ থেকে যা শিখলাম তা অবশ্যই ফিউচারে বিভিন্ন জায়গায় আমাদের অনেক কাজে আসবে। এই পর্যায়ে আমি আগামী 12 তারিখে আমাদের তৃতীয় পর্ব দেখার আমন্ত্রণ জানাচ্ছি সবাইকে। আগামী পর্ব অর্থাৎ হেলথ টকের তৃতীয় পর্বে আমাদের সাথে রয়েছেন প্রফেসর আহমেদুল কবির স্যার। তিনি আমাদের সাথে আপার যে এন্ডোস্কোপি নিয়ে আলোচনা করবেন। ততদিন পর্যন্ত ভালো থাকবেন, সুস্থ থাকবেন, আমাদের সাথেই থাকবেন। শুভরাত্রি, আল্লাহ হাফেজ।